Dry eye disease, symptoms, causes, and modern treatments. Ever feel like your eyes are perpetually parched, gritty, or just plain uncomfortable? This irritating sensation is often a telltale sign of dry eye syndrome, a remarkably common condition that occurs when your eyes don't produce enough quality tears, or when those tears evaporate too quickly. This article provides information to help readers understand dry eye as a medical condition, a disease, exploring its symptoms, causes, potential consequences if left untreated, and the wide range of available treatment approaches, including how it interacts with other eye health concerns like high eye pressure and cataracts. The unsung heroes, tears. Understanding the role your tears play can be helpful in comprehending dry eye. Tears form a sophisticated, protective film over your cornea, the clear front surface of your eye. This tear film, essential for clear vision and protecting the surface, is composed of three crucial layers, each with a specific function. The oily layer, from meibomian glands. This outermost layer originates from tiny oil glands, called meibomian glands, located along the edges of your eyelids. This layer helps to seal the tear film, reducing tear evaporation and maintaining tears on the eye's surface. The watery, aqueous, layer, from lacrimal glands. This middle and thickest layer is produced by your main tear glands, called lacrimal glands, located just above the outer corner of your eye. It provides the majority of the moisture, assisting in washing away debris and delivering vital oxygen and nutrients to the eye's surface. The mucus layer, from goblet cells. The innermost layer, produced by tiny cells on your eye's surface, helps the watery tears spread evenly and adhere to the eye's surface, ensuring comprehensive coverage. When any of these layers are out of balance or compromised, the delicate tear film may become unstable. This instability is a contributing factor to the symptoms of dry eye. What dry eye may feel like. The symptoms of dry eye can vary from mild to significant. Common sensations often include a persistent stinging, burning, or scratchy sensation in your eyes. A feeling as if there's something gritty in your eye. Redness in the eyes. Blurred vision, which may improve after blinking. Increased sensitivity to light, photophobia. Difficulty or discomfort when wearing contact lenses. Eye fatigue or a sensation of heaviness, particularly after reading or screen time. Occasional stringy mucus in or around your eyes. Paradoxically, excessive watering of the eyes. This can be a reflex response to irritation from dryness. However, these reflex tears often lack the necessary oils and mucus to properly lubricate the eye, resulting in temporary relief. It is important to note that many dry eye symptoms, such as itching, burning, and excessive watering, can also overlap with those of allergic conjunctivitis, eye allergies. Both conditions involve inflammation on the eye's surface, and one can worsen the other. For instance, dry eye can make eyes more vulnerable to allergens, while severe allergies can trigger inflammation that damages tear-producing glands. This symptom overlap highlights the importance of accurate diagnosis by an eye care professional, as treatment approaches differ for each condition. Potential causes of dry eye. Dry eye can be triggered by a wide array of factors. These can often be grouped into several categories. Biological and age-related factors. Aging. Tear production tends to decrease with age, contributing to dry eye prevalence in individuals over 50. Hormonal shifts. Hormonal fluctuations, such as those during pregnancy, with birth control use, or during menopause, may increase susceptibility, particularly in women. The role of hormone replacement therapy, HRT, in postmenopausal women can be complex. Depending on the specific type and individual response, HRT may influence or be a factor in dry eye symptoms. Some forms of HRT, particularly those with higher estrogen doses, have been associated with changes in tear film stability, while others might have a neutral or even beneficial effect depending on the individual's hormonal balance and tear gland function. Meibomian gland dysfunction, MGD. This is a leading cause of evaporative dry eye. If the tiny oil glands in the eyelids become clogged or do not produce sufficient high-quality oil, tears may evaporate too rapidly, leaving the eyes less protected. Eye surgery. Previous eye surgeries, including LASIK, may temporarily or, in some cases, chronically affect tear production or corneal nerve sensation. Medical and medication-induced factors. Medical conditions. Certain autoimmune diseases, e.g., Sjogren's syndrome, rheumatoid arthritis, lupus, along with thyroid disorders, and eyelid inflammation, blepharitis, an irritation or infection of the eyelids, can significantly affect tear production or quality. Medications. Numerous common medications, including antihistamines, decongestants, antidepressants, certain blood pressure medications, and some acne medications, may have dry eyes as a side effect. Informing an eye doctor about all medications taken can be important for comprehensive assessment. Environmental and behavioral factors. Environmental factors, dry, windy, or smoky conditions, as well as prolonged exposure to air conditioning, heating, or ceiling fans, may increase tear evaporation. Digital screen use. Prolonged viewing of computers, phones, or tablets is associated with reduced blink rates, potentially up to 50% less, which can lead to increased tear evaporation and dryness. A common suggestion for screen use is the 20-20-20 rule, looking at something 20 feet away for at least 20 seconds every 20 minutes. Contact lens wear. Long-term contact lens use may contribute to or exacerbate dry eye symptoms. Psychological and systemic influences. Psychological factors. Conditions such as anxiety, depression, and chronic stress are increasingly recognized as potentially influencing the perception or severity of chronic pain, including ocular discomfort associated with dry eye. The intricate connection between the mind and body means that emotional stress can potentially affect nerve pathways involved in tear production or increase overall pain sensitivity, potentially making dry eye symptoms feel more intense even if the physical signs of dryness remain constant. Is dry eye a disease? And its potential progression. Yes, dry eye is widely recognized as a disease, often referred to as dry eye disease, DED, or dry eye syndrome, DES. It is a complex condition affecting the surface of the eye, involving multiple factors that disrupt tear film stability and overall eye health. Current understanding emphasizes that dry eye involves a loss of balance of the tear film, indicating a disruption in the delicate components of tears. This disruption can lead to ocular symptoms, the sensations of discomfort, burning, grittiness, and blurred vision. Tear film instability. Tears may break up too quickly or lack consistency, failing to adequately protect the eye. Tear hyperosmolarity. Tears may become excessively salty, which can be irritating to the eye surface. Inflammation and damage to the eye's surface. Persistent irritation may lead to inflammation and damage to the delicate cells on the front of the eye over time. Neurosensory abnormalities. Issues with nerve function may also play a role in the sensation of dryness. If left unaddressed, dry eye can potentially worsen. It is often described as a chronic and progressive condition, meaning its severity can increase over time without appropriate management. Potential progression includes 1. Increased discomfort. Initial irritation may escalate into constant, severe burning, stinging, grittiness, and a persistent foreign body sensation, potentially impacting daily activities and concentration. 2. Visual disturbances. Blurred vision may become more frequent or severe, potentially affecting tasks such as reading, computer use, or driving. In some cases, double vision may develop. 3. Damage to the eye surface. Inadequate lubrication and ongoing inflammation can lead to corneal abrasions, tiny, painful scratches on the corneal surface due to friction from blinking. These abrasions can also create entry points for pathogens. Corneal ulcers. untreated abrasions or infections may progress to corneal ulcers, open sores on the cornea. These are serious, potentially causing intense pain and leading to permanent vision loss if infected. Corneal scarring. Prolonged inflammation and recurrent damage can form opaque scar tissue on the cornea, permanently affecting vision by blocking light. Conjunctivitis. Persistent dryness and irritation may also lead to chronic inflammation of the conjunctiva, the clear membrane covering the white part of the eye. For increased risk of eye infections, tears contain natural antibacterial components. A compromised tear film can weaken this protective barrier, increasing vulnerability to bacterial or viral infections. 5. Impact on quality of life. Severe dry eye may significantly impact daily life, potentially limiting social activities, outdoor enjoyment, and productivity at work or school. Furthermore, psychological factors such as anxiety and depression may not only result from chronic ocular discomfort but can also, in turn, influence the perception and severity of dry eye symptoms. The constant struggle with discomfort and visual issues can be mentally taxing, leading to heightened stress, which can then further aggravate the physical sensations of dryness through nerve pathways and systemic inflammation, potentially creating a challenging and persistent cycle. 6. Difficulty with contact lenses. For contact lens wearers, dry eye can make lenses increasingly uncomfortable or impossible to wear, often necessitating a switch to glasses. Dry eye's relationship with other eye diseases, a complex interplay. Understanding how dry eye may interact with other common eye conditions is important. While dry eye does not directly cause these issues, its presence can significantly influence symptoms, diagnosis, and particularly treatment outcomes. Dry eye and high eye pressure, ocular hypertension, / glaucoma. No direct causation. Dry eye itself does not cause high eye pressure, ocular hypertension, or glaucoma, a disease that damages the optic nerve, often due to high eye pressure. High eye pressure relates to internal eye fluid dynamics, while dry eye affects the eye's surface. Crucial treatment interaction. A significant connection lies in treatment. High eye pressure, ocular hypertension, is a primary modifiable risk factor for glaucoma, and treatment to lower this pressure is considered preventative glaucoma treatment. Many conventional glaucoma eye drops, particularly those containing preservatives like benzalkonium chloride, BAK, are known to be irritating and potentially toxic to the ocular surface with long-term use. This may significantly worsen existing dry eye or induce new dry eye symptoms, potentially creating a challenging cycle. Potential for compliance issues. Discomfort caused by glaucoma drops may lead individuals to reduce or discontinue medication, which is a significant concern for glaucoma management due to the risk of irreversible vision loss. Diagnostic interference. Severe dry eye may also interfere with the accurate measurement of eye pressure, tonometry, during eye exams. Dry eye and cataracts. No direct causation. Dry eye does not cause cataracts, a clouding of the eye's natural lens, nor do cataracts cause dry eye. Both are common age-related conditions and thus frequently coexist. Impact on cataract surgery. Untreated dry eye may significantly affect the accuracy of measurements for intraocular lens, IOL, implants during cataract surgery. An unstable tear film can lead to incorrect IOL power calculations and potentially suboptimal vision post-surgery. For this reason, optimizing dry eye management before cataract surgery is often considered. Postoperative exacerbation. Cataract surgery itself may temporarily worsen existing dry eye or induce new symptoms. This can be due to surgical effects on corneal nerves, exposure during surgery, and the use of preservative-containing postoperative eye drops. Managing dry eye both before and after surgery is often considered vital for patient comfort and achieving optimal visual outcomes. Comprehensive dry eye treatment approaches. Dry eye is a manageable condition, and effective approaches may significantly improve comfort and eye health. Treatment strategies are typically individualized, depending on the underlying cause and severity of symptoms. Working closely with an eye care professional is often important for determining an appropriate plan. 1. Medications for dry eye. While eye drops applied directly to the eye are a primary tool, medications for dry eye encompass a broader range of forms and actions. Over-the-counter, OTC, eye drops, artificial tears. These are a common initial recommendation for mild to moderate dry eye. They function by lubricating and moisturizing the eye's surface, helping to replenish the watery layer and stabilize the tear film. Some formulations include lipids/oils to reduce evaporation. Consideration: for frequent use, more than 4 to 6 times a day, or for sensitive eyes, preservative-free, artificial tears, often available in individual single-use vials or multi-dose bottles with special filters, are commonly suggested. Preservatives in regular drops may irritate sensitive eyes over time. Redness reliever drops are generally advised against for dry eye, as they may cause rebound redness and potentially worsen dryness in the long run. Prescription eye drops. For more persistent symptoms or when inflammation is a key factor, an eye doctor may prescribe stronger, targeted drops. Immunomodulators, e.g., cyclosporin, lifitegrast. These anti-inflammatory medications suppress immune responses that may contribute to inflammation, potentially allowing the eyes to produce more and better quality natural tears over time. Full benefits may take weeks to months to be observed. Corticosteroid eye drops, potent anti-inflammatory agents sometimes used for short-term relief of acute, severe inflammation. Due to potential side effects like increased eye pressure or cataracts with prolonged use, their use is typically for a limited duration. Tear evaporation modulators, e.g., perfluorohexyloctane, a newer class of drops primarily for evaporative dry eye, MGD, which may create a protective layer on the tear film to help inhibit tear evaporation. Oral medications. Taken by mouth, these medications exert systemic effects. Oral antibiotics, e.g., doxycycline at low doses, these may have anti-inflammatory effects that can improve the quality of oil produced by meibomian glands. They are sometimes prescribed for chronic MGD or ocular rosacea. Oral cholinergic agonists, e.g., pilocarpine, primarily for severe dry eye, especially with autoimmune conditions like Sjogren's syndrome. These may stimulate tear and saliva production. Oral anti-inflammatory/immunosuppressants. If dry eye stems from a systemic autoimmune disease, medications prescribed by a rheumatologist to manage the underlying condition may also alleviate ocular symptoms. Nasal sprays. Varenicline, Trevea. This nasal spray can activate nerve pathways in the nose that may stimulate the eye to produce more of its own natural tears, offering an alternative for those who may have difficulty with eye drops or experience sensitivity to them. Eye inserts/ointments, topical. Ointments. These are thick, gel-like or petroleum jelly-like formulations that coat the eye, providing extended lubrication and helping to prevent tear evaporation. They typically cause significant temporary blurry vision and are often used at bedtime for severe dryness. Ocular inserts, e.g., Lacrosert, small, dissolvable pellets that can be placed in the lower eyelid sac. They slowly release lubricating ingredients onto the eye's surface over several hours, providing continuous lubrication. Nutritional supplements. Omega-3 fatty acids, oral supplements, often from fish oil or flaxseed oil, have anti-inflammatory properties that may help reduce inflammation throughout the body, including in the meibomian glands. This may contribute to a more stable tear film and reduced evaporative dry eye. Discussion of appropriate dosage with a healthcare professional may be considered. Two, lifestyle adjustments. Certain lifestyle adjustments may contribute to dry eye management. Avoiding excessively dry, windy, or smoky environments. Using a humidifier in the home or office, particularly during dry seasons or in air-conditioned/heated rooms. making a conscious effort to blink more often, especially when using screens. Full blinking is generally encouraged. Taking regular breaks when concentrating on digital devices, referencing the 20-20-20 rule. Wearing wraparound sunglasses outdoors to help protect the eyes from wind, sun, and dry air. Practicing good eyelid hygiene with warm compresses and gentle eyelid scrubs, particularly if MGD or blepharitis is present. Staying hydrated, by consuming sufficient water, is often considered beneficial for overall bodily functions. In-office procedures and surgical interventions. When conservative measures may be insufficient, certain in-office procedures or surgical interventions may be considered. These approaches often target specific underlying issues or enhance tear retention and are typically performed in a doctor's office or an outpatient surgical center. Punctal occlusion, punctal plugs and cautery. Punctal plugs, these are tiny, sterile devices, often made of silicone or dissolvable collagen, inserted into the puncta, the small drainage holes in the inner corner of the eyelids. By blocking these drainage points, the plugs may help keep natural tears, and any artificial tears used, on the eye's surface for a longer duration, potentially improving lubrication. The procedure is typically quick. Punctal cautery, a more permanent procedure where heat is used to close the tear drainage ducts, which may be considered if plugs are effective but repeatedly dislodge. Procedures for meibomian gland dysfunction, MGD. Thermal pulsation systems, e.g., LipiFlow, tear care. These devices apply controlled heat and gentle massage to the eyelids, which may help to melt and express blockages in the meibomian glands, potentially improving oil flow. Intense pulsed light, IPL, therapy. This involves the application of light pulses to the skin around the eyelids. It is believed to reduce inflammation, potentially improve gland function, and address underlying issues. Meibomian gland probing/expression, a procedure where a fine probe may be used to physically unblock stubborn obstructions within the glands, followed by manual expression. Amniotic membrane grafts, e.g., Procra. For more severe cases, particularly those involving corneal damage, a sterile membrane derived from the human placenta may be placed on the eye. These membranes are thought to possess healing and anti-inflammatory properties that may support the eye's surface recovery. Eyelid surgery, blepharoplasty or lid repair. If dry eye is caused or worsened by eyelid abnormalities, e.g., eyelids turning in or out, or not closing completely, surgical correction may significantly improve symptoms by allowing the eyelids to properly protect the eye. Salivary gland transplantation, this is a highly specialized and rare major surgery, generally reserved for extremely severe, refractory dry eye cases, e.g., due to severe autoimmune disease, where the eye produces very few tears. It involves transplanting a minor salivary gland to provide continuous moisture. Tailoring treatment, dry eye with high eye pressure but no glaucoma. For individuals who experience both dry eye and elevated eye pressure, ocular hypertension, but have no definitive diagnosis of glaucoma, meaning no optic nerve damage or visual field loss, the treatment strategy can be particularly nuanced. An approach aiming to minimize complications and ensure effective management of both conditions is often considered. The primary difference from a diagnosed glaucoma case typically lies in the urgency and intensity of pressure-lowering interventions, as the immediate threat of irreversible vision loss from glaucoma may not yet be present. This allows for strategies that may prioritize ocular surface health and patient comfort. 1. Observation versus treatment initiation. Unlike diagnosed glaucoma, where pressure-lowering treatment is almost always initiated immediately, individuals with ocular hypertension may initially be placed on careful observation. An eye doctor typically monitors eye pressure regularly and assesses risk factors, e.g., pressure level, corneal thickness, and optic nerve appearance, before deciding whether to begin treatment. If the risk of developing glaucoma is deemed low to moderate, monitoring may be preferred over immediate medication, potentially avoiding associated dry eye side effects. 2. Prioritizing preservative-free, PF, pressure-lowering drops. If pressure-lowering drops are deemed necessary, ophthalmologists often prioritize preservative-free formulations, e.g., specific types of preservative-free latanoprost. This eliminates exposure to BAK, benzalkonium chloride, a common preservative that is a major contributing factor to dry eye exacerbation, which may help preserve ocular surface health and patient comfort. 3. Emphasis on laser therapy, selective laser trabeculoplasty, SLT. Ocular hypertension with coexisting dry eye, SLT may be considered an appealing initial treatment. This in-office laser procedure can effectively lower eye pressure by improving the eye's natural drainage, often reducing or potentially eliminating the need for daily eye drops for a period. This approach may bypass ocular surface irritation associated with drops, potentially leading to better dry eye management. 4. Aggressive standalone dry eye management. Since the primary goal is not solely to tolerate glaucoma drops, dry eye management can be pursued proactively and independently. This may involve early initiation of prescription anti-inflammatory dry eye drops, diligent attention to meibomian gland dysfunction, MGD, with in-office procedures and at-home care, and the consideration of punctal plugs. 5. Flexibility in treatment choice. An ophthalmologist may have greater flexibility in selecting pressure-lowering agents. There may be less immediate pressure to choose the most potent, but potentially more irritating, option if the optic nerve is healthy, allowing for choices that may be both effective for IOP and gentle on the ocular surface. Understanding and managing dry eye. Understanding dry eye as a genuine medical condition, a disease, is an important step toward potentially finding relief. From understanding the delicate balance of tears to recognizing the many factors that can contribute to symptoms, readers can gain a clearer picture of this complex condition. This article has explored various approaches, from over-the-counter options and lifestyle considerations to prescription medications, in-office procedures, and even surgical possibilities. Crucially, the interaction of dry eye with other eye conditions like high eye pressure and cataracts highlights the importance of a comprehensive and individualized approach to eye health. For individuals experiencing persistent dry eye symptoms, consultation with an eye care professional, optometrist or ophthalmologist, is generally recommended. An eye care professional can accurately diagnose the specific type of dry eye, assess any related concerns, and develop a tailored treatment plan that may offer lasting comfort, assist in preventing disease progression, and contribute to the protection of vision. Consistent management is often considered key to maintaining optimal eye comfort and visual function.